Coming up next on Being Well, Dr. Ruben Boyajian from Effingham will be my guest this week. Dr. Boyajian is a surgeon who specializes in the treatment of breast cancer. We'll be learning more about how breast cancer is diagnosed and how the treatment has evolved over the years. We'll also learn more about how the treatment is customized based upon several factors. We've got a lot of information to cover, so let's get started. Production of Being Well is made possible in part by Sarah Bush Lincoln Health System, supporting healthy lifestyles, eating a heart-healthy diet, staying active, managing stress, and regular checkups are ways of reducing your health risks. Proper health is important to all at Sarah Bush Lincoln Health System. Information available at sarahbush.org. Alpha Care, specializing in adult care services that range from those recovering from recent hospitalizations to someone attempting to remain independent while coping with a disability, chronic illness, or age-related infirmity. Alpha Care, compassionate professional home care. Additional funding by Jazzercise of Charleston. Well, I am so pleased that Dr. Ruben Boyajian from Effingham has come to visit Being Well for the first time.
Thank you.
Thank you so much for coming this way. Tell us a little bit about your practice and the types of cases that you deal with.
Well, we do general surgery, which it's the run-of-the-mill, gallbladders and hernias and endoscopies. But my main interest always has been breast care. Particularly with breast cancer issues.
And tell us about your role as the director of the Women's Wellness Center at St. Anthony.
That has been a very rewarding program. We started that a few years ago to emphasize the issues of prevention, early diagnosis in breast cancer, other breast illnesses, and motivating women to get their mammograms on time and regularly. It's amazing how many women do not get their mammograms as a routine, diagnostic and screening method to detect breast cancer at early stage.
Well, I don't want to say you've been around for a while, but we were talking earlier before we started taping about there has been a lot of changes in breast cancer and breast cancer treatment and care and surgery. You want to talk about some of the big things that have happened that you've seen in your time in the field?
I think being older gives you the advantage of looking in the past and learning from experiences, and also witnessing a tremendous amount of progress in the field. I trained in New Haven in Connecticut. Late 70s was a time where the changes were so impressive, such as introduction of chemotherapy for the first time.
That didn't happen until the 70s?
Late 70s,
all right.
Correct. This was a trial by Bonadonna from Italy that introduced the CMF type of chemotherapy that made a major difference on patients with advanced breast cancer. And at the same time, the mammography came along, became more sophisticated as a diagnostic method for a screening of breast cancers. And then, through Dr. Fisher's research, the transformation from radical mastectomy into lumpectomies with breast preservation. So all this happened in a relatively short period of time. From there on, we witnessed all the advances in genetics, more sophisticated targeted chemotherapy designed exclusively for particular situations, because the breast cancer is different at every age, different racial groups and the extent of disease, the type of cancer. So it's been definitely tailored to the needs of the person, the women, and sometimes men, because we do get breast cancer as well.
Can you give us right now, what are our current breast cancer statistics here in the United States?
They are frightening, I
Okay.
say. We still, in the year 2015, we expect to diagnose over 230,000 cases of breast cancer and an additional 60,000 cases of pre-cancer situations called DCIS.
Okay.
And of this group, about, unfortunately, 40,000 women will die from the disease still.
Is that number going up, the number of women dying from it, or are we doing better?
That has improved.
Okay.
Since the mid-90s, the death rate has decreased to over 34%. And the diagnosis has increased, and now it's kind of plateau.
We talked earlier about that there are some risk factors that you can control and some that you can't, like genetics. Can you talk about the risk factors for breast cancer?
There are some risk factors that is out of our control. For example, being a woman is a risk factor, first one. The racial, the Caucasian and the Western civilization has a higher incidence of breast cancer. The age at the first menstruational period, called menarche, the younger the age, the higher the risk. Late menopause, meaning past age 55.
Okay.
Lack of pregnancies, nulliparous, meaning no pregnancies have occurred, is a high risk. First pregnancy after the age of 30 is also a higher risk. Obesity, smoking, alcohol, all the fun stuff, then we want to take away.
It seems like some of those factors, when we had Dr. Philip Dion, who's a colleague of yours a while ago, some of the same risk factors for breast cancer are similar for ovarian cancer.
That is very true.
And what is the connection between the period and ovulation and getting cancer later in life? I don't understand kind of how those work hand in hand.
I call it the fertilizing atmosphere.
Okay.
You know, because this is a time of life where fertilizing hormones such as estrogen, progesterone will actually be consumed by rapid growing cells. They love that. And the majority of cancers are hormone sensitive, particularly in the years of, a normal menstruation or otherwise. And therefore, it becomes an issue of tremendous importance, that realizing that the breast cancer and the ovaries are two areas of the system in a woman that is constantly undergoing changes. All right? The ovaries are producing the ovulation, and then they have to retreat. Then they have to, I call it, the expected pregnancy, most of the time doesn't occur. The breast has to gear up to, producing milk, and that may or may not happen. So the changes are just very rapid and constant, month after month.
So it's that hormones up and down and up
Correct.
and down that cancer likes. Is that kind of a way to put it?
Correct.
Okay.
Yeah.
That's interesting. Another thing that we hear a lot about is the genetic testing and the BRCA gene. Talk a little bit about that and clarify that for our viewers.
Well, as far as we know, the current knowledge, and that is well established, is the BRCA1 and 2. These are genetic tests that are readily available with a high degree of accuracy. However, it's very important to know that the majority of breast cancers are not hereditary.
Okay.
And only 5 to 10% maximum will be, affected by heredity and be transmissible. And of course, as the general public, has we all have fear whether am I gonna get it or not, or if you have a close relative that had the cancer, is it gonna increase my risk? So all these issues are clarified through consultations, and if we follow the guidelines and the candidate qualifies for the BRCA test, then we make sure we schedule it. It's an expensive test. Yeah.
So do you recommend that to patients? What are your thoughts
We
on
try
it?
to educate them. There are qualifiers and there are not. For example, if the cancer occurred in a woman that younger than 45, the testing is recommended.
Okay.
If the person has the cancer at an age younger than 50, but there is a close relative, let's say a sister or mother that had breast cancer, we recommend the testing. And then there's also the male sector or the male factor. If there are some families that don't have very many females in the family and they're all boys, and then you assume that there is no breast cancer here. But if there is a history of pancreatic cancer or aggressive prostatic cancer, that means that the BRCA gene could be in the family. So
and
we
as
look,
you said
we look
earlier,
at those issues as well.
Men can get breast cancer. It's not very common, correct?
Well, it's for every 100 women that will have breast cancer, only 1 man will have it.
That's interesting. Talk about breast cancer is not just breast cancer. There are different types in different places. Can you clarify that for our viewers out there?
The most common cancer is the invasive ductal carcinoma.
Okay.
That's about 70 to 80%. Then there's a smaller percentage. The one that follows is called lobular invasive cancer. And then there's a number of other names like tubular, medullary, mucinous. Those are a lot less frequent. So the majority of cancers are called invasive ductal.
Are those different types, is one more aggressive than the other or harder to treat than the other?
The invasive ductal takes the lead. It's usually the more aggressive. There is also another variety that is not very common called metaplastic, and that could be very aggressive.
So you had talked about that one of the biggest changes is in the treatment plan, that it's not just, you don't go through a checklist and go, okay, you have this is how we're going to do it. The treatment has really become customized to the patient. So why don't you talk a little bit about how you as doctors determine the treatment plan for a woman who has breast cancer?
We don't just go from the consultation room to the operating room. You know, that used to be done in the old days. It's still done in some areas, but we follow the multidisciplinary approach. So the patients are seen by the oncologist following the diagnosis through core biopsies usually. And then depending on the pathology report and looking at all these issues that we have talked about, is the tumor hormone sensitive, you know, is HER2 new, which is a protein that stimulates growth. Is it positive or not? Is it a triple negative cancer? The age of the woman, the size of the breast, the size of the tumor. Is the person a candidate for breast conservation? Can we just do a lumpectomy and keep all the profile and the normal feminine anatomy as intact as possible? Does the patient need lymph node sampling, and to what extent? So these are all a large number of variables.
And that is when you come into play. You're
Correct.
the surgeon, and so you consult with the patient over their options. So it's not just radical mastectomy.
Correct. Yeah. In fact, the majority of the cancers are not treated by mastectomy anymore.
Is that something that you said has changed?
Yes.
Okay.
Lori, it has changed mostly because due to the fact that the discovery of cancer at the time we find the tumor has evolved from large cancers to very small ones. The ideal is to find a cancer when it's less than 2 centimeters or less than 1 inch in diameter. The smaller the cancer, the higher the probability of cure. And also, you know, when the cancer is a small one, we have to remove less breast tissue, obviously.
When does reconstruction come into play? Because that's that's part of a woman's identity.
Right.
When I'm guessing that's a common question that they get.
Yes.
How do you decide when someone can have the reconstruction?
It all depends. Here we follow the lead of the patient, the woman, and the family. And also we have to match the implications of the treatment and what is it going to do to the system and what potential deformities will occur. And then the reconstructions are also tailored. You know, if the woman is very large breasted, let's say, and she also wants a breast reduction of the opposite breast, then we have to consider that. And some of the reconstructions involve placement of tissue expanders that are later changed into the prosthetic, and then the nipple is recreated. Some of the reconstructions are based on free transplants of tissue into the area. It's also affected whether the patient will have chemotherapy and or radiation or not, because those treatments can affect the healing and the timetable of the reconstruction as well.
So where does the chemo part and the radiation part come into play, and how do you determine if a patient needs one or the other or both after surgery?
Thank you for asking that question. Well, see, the results of the lumpectomy or partial mastectomy, these are equal terms, to the traditional mastectomy are equal as long as the patient has radiation treatment after the partial mastectomy. So that's the main role of the radiation.
Okay.
In some cases where the lymph node involvement is significant, let's say axillary or in the neck, then radiation treatment to those areas is also provided.
What about when does chemo come in? Or is one used more than the other? Is one more?
I'm sorry.
Okay.
Chemotherapy is also a very customized treatment. You know, if the tumor is estrogen sensitive, we have easy medications that are easily taken, like tamoxifen that blocks the hormones, and as simple as that. If the tumor is a triple negative, so-called, is not hormone sensitive, then more aggressive chemotherapy is indicated. It also makes a difference if the tumor is reoccur, if there is metastasis or a spread to other areas as well.
I was going to ask about cancer spreading. Does breast cancer have, like other cancers, kind of a typical path? If it's going to spread, it's generally going to go here, here, and here? Or is it, don't you know?
Actually, it does. Actually, it does. The breast likes bone, and it doesn't like to go to the, let's say, gastrointestinal system. It may go to the liver, sometimes brain, but bone is a very frequent site for metastases.
How about what about the lymph nodes? You often hear of women who have maybe the surgery and then they also have a few lymph nodes taken out. Why do you do that?
It's really for staging and trying to see if the horses are out of the barn or not. You know, because the lymph nodes are a barrier, a defense. So the network of the lymphatic drainage of the breast is so rich, and most of it goes to the axillary area. So that has evolved into doing a very limited sample called sentinel node. So we only need to take 1, 2, or 3 nodes to really figure out if spread to the lymphatic system has occurred or not. And that could be a modifier as far as the treatment, whether the patient will need chemotherapy or not, and or radiation therapy as well. So
I wanted to ask you, what are the most common concerns or questions that patients ask of you when they find out that they have this diagnosis? It's very scary, and maybe you're going to have surgery. What are some things that you hear?
It's a very difficult time, obviously, and we try to place ourselves in the position of the patient and try to understand their environment, their support system. They want to know if they're going to be cured or not. Second common question is the fear of rejection, losing the job, the sources of income, you know, losing the insurance is a huge one. Then the cosmetic implications. So those are very common questions. And if we try to analyze the patient's social situation as well. There's also fear of rejection by the spouse or significant other. So all these things do appear. But the leading question is always, you know, the probability of cure, is the cancer ever going to come back, and is it going to be transmitted to my family, and should I get genetic testing? So these are very common questions.
How do you determine, I should ask this first, is breast cancer staged like lung cancer and ovarian cancer? Does it have stages that you give it?
Yeah, we have a precise staging system based on the size of the tumor, the spreading to the lymph nodes and or other organs.
Okay. So can you talk about cure rates or survival rates based on the stages?
Great question.
I'm going to put you on the spot.
Great question. And here comes to the concept of DCIS, ductal carcinoma in situ. In situ means that the cancer has not broken through the membranes of the tubing or the tubes that form the breast. So when those are discovered, the cure rate is almost 100%. The second is the cancer less than 2 centimeters or less, or half an inch or less. Then with lymph node negative, the cure rate is 93-95%. With lymph node involvement, it goes down to 70%. If there is metastasis, now we are dropping to 20%. So it has a lot of importance in predicting the potential outcome, and also prepare and customize the weaponry, knowing those probabilities.
And it sounds like you have a lot of things in your arsenal to help with
Correct.
surgery, chemotherapy, radiation, that sort of stuff. I want to get back to mammograms a little bit. It seems that sometimes in the popular media there's this debate, and maybe in the medical community, mammograms every year, and then it came out now it's every couple of years, or they're not great at detecting breast cancer in younger women. Sometimes as a woman, you're just like, I don't know what to do.
Lori,
what should we do?
I have a large number of patients that had a normal mammogram the year prior, and the next year they have a tumor that is discovered. Knowing and having experienced that, I refuse to step back and say that the mammography it can be done at increasing intervals. So mammogram after age 40 yearly is the standard. This has been challenged by some of the government agencies, task force, and through our societies, the American Cancer Society, we are very strong, and we have fundamental issues with it, that mammography should continue after age 40 on an yearly basis.
In fact, I have a letter sitting at home telling me it's, my year is up and I need to go in. So after taping this, I think I'm going to make my appointment and get that taken care of.
Sure. Yeah. And modifications are introduced. Let's say if the person is BRCA positive or a strong family history, even if the BRCA is negative, then we start mammography at an earlier age, 25, 30 sometimes.
Does the mammogram can it show everything, even those tiny?
No, it doesn't.
Okay.
And I'm glad you asked that question, because the density is another buzzword right now.
Yes, I've heard that many times.
Yeah, it started in the state of Connecticut. There's a history behind that. But the density of the breast is increase. It will increase the risk for breast cancer, and it makes the diagnosis more difficult. You have a very thick breast tissue that looks all white on the mammogram, and you can't tell. So those persons qualify for ultrasound of the breast as a screening method, and sometimes the MRI.
And I'd imagine the technology in mammography, just like the technology in what you're doing treatment-wise, is always getting better.
It's getting better. We're going to 3D mammography now. It's got its drawbacks too. Example, 3D mammography, a lot of patients are asking for it. We are getting it in Effingham. But you know what? When it comes to calcifications or microcalcifications, it's not as accurate. So, we have to use all this technology wisely. And there's not one recipe for all.
I wanted to ask you, as we wrap up here, what advice can you give to a woman who's just newly diagnosed? What would you say to them?
I would say, first of all, reassure and have a lot of transparency and clarity on what we're doing. We issue copies of the pathology report to all the patients, share all the findings with them. We give them instructions in the form of printed material and accessibility to websites. And I think education is very fundamental. And that knowledge gives power to realize that it's not the end of the life, and transform the fear into an energizing factor. And we have many situations where the patient becomes an advocate, helps other patients, and he faces the treatment with more optimism and ready to go on. So.
Well, Dr. Boyajian, I want to thank you for coming to the show. You've provided some great information for our viewers that I know they'll appreciate, and we hope to have you back again sometime soon.
Thank you. I do appreciate the opportunity and the interest that you have expressed. So thank you very much.
Thanks.
Yeah.
Being Well is also available online at our YouTube channel, youtube.com/WEIUTV. Just look for the Being Well playlist. Here you can view current as well as past episodes. Production of Being Well is made possible in part by Sarah Bush Lincoln Health System, supporting healthy lifestyles. Eating a heart-healthy diet, staying active, managing stress, and regular checkups are ways of reducing your health risks. Proper health is important to all at Sarah Bush Lincoln Health System. Information available at sarahbush.org. AlphaCare, specializing in adult care services that range from those recovering from recent hospitalizations to someone attempting to remain independent while coping with a disability, chronic illness, or age-related infirmity. AlphaCare, compassionate professional home care. Additional funding by Jazzercise of Charleston.